Do you have plans for additional career as an author?
Uh, yes, I'm writing a whole series of just anecdotes that I remember from my political and medical life, which I'm calling Tales of the Sausage Factory, but it's still in a very raw form. Thank you for plugging the book, and it is available through all the usual sources. My books have been endorsed by Maya Angelou, U.S. Senator Ben Cardin, U.S. Senator Chris Van Hollen, Dr. Leanna Wen, a whole bunch of famous people, including Tara Brach, a locally well-known Buddhist meditative leader, a friend of mine, Jason Pauling, who's an evangelical Christian minister. So we run the gamut of folks. But it is an equity issue because also in doing research when I was on the faculty at Johns Hopkins on the rate of completion of advanced directives across the population, while we found that only 40% of Americans had done this, and should be 99%, it was about half that in the minority population. And so that I was the first to formally identify that as a minority health disparity. And so I do as much outreach I can to communities of color and poor communities and say, hey, here's free forms and it empowers you. But there's a distrust of the healthcare system. There's a skepticism about it, and we have to overcome that.
And how do we do that, Dan? We talked about the reasons why. It goes back many, many years. How do we overcome that distrust? I mean, I've heard, I wish I said this, it wasn't my quote. It was, I think, Dr. Chen and Chen Med. He said basically, we don't have a problem of science in healthcare. We have a problem of trust. And that's what you just alluded to. Why is that? And what can we do about that?
Boy, if I knew the answers to that, I'd be much more effective than I am. But that I try all the time to. That's something I wrestle with all the time. How do we communicate? How do we connect with people? Part of the job of an ER doctor is you got to walk into a room, whether it's a minor issue, and most are not major emergencies, and you got to connect with people in 30 seconds. And I've developed a number of approaches to do that, and that's one-on-one, one at a time, and we have to. Work on that on a much broader scale. But as I think everybody acknowledges, we're in a big divide in this country right now about being civil with each other, about trusting, about not attacking each other. We can disagree, but we're tending to do it very disagreeably instead of agreeably. So the only things I know how to do is just be persistent, try to stay optimistic, and spend as much time as you can in improving listening skills and communication skills, and try to get to the heart of the matter with folks. But it's a challenge. I think that's a key question, David. I wish I could give a better answer. So I'm just doing, I think each of us, it's incumbent on us to do the best we can.
How do we get 5,000 Dan Morheims out there? How do we teach the skills that I'm going to argue maybe innate with you? Well, let me ask you the question. The skills you just talked about, the most important skills as a physician, connecting with your patient. They're not just another number. The skills that you just outlined, did you have to learn those skills, or were they innate?
I would say I learned, I observed, and some were innate. So all of the above. And I'll just give you a few right out of the emergency room, but also worked very well for me when I was campaigning door to door, which is a former mailman. It's pretty good carrying a bag with good stuff training in it and finding addresses. So. I'll give you a couple examples. So most cases, the emergency room are not, when there obviously is a raging emergency, you just have to step in and act. There's no time, but that's not the thing that happens most often. So I would do little things, like I would always come in the room and I would try to park myself physically in the room with the patient. That could be bringing in a stool and sitting on it, or leaning against a wall, or if appropriate, kind of sitting at the foot of their bed. So they knew I was physically present rather than kind of half in and half out of the room, like poised to leave. I would always get everybody to say their name. So if there was not only the patient, I would introduce myself. I'm Dr. Dan Morhaim. You call me Dr. Dan or Dr. Morhaim, and you are. And then I would get every person to say their name and how they were connected with the patient, family members or around. There's something that happens when people say their own name. You can actually almost visualize it. Something changes in their brain and their chemistry that they now feel we're not anonymous. There's a connection, as opposed to just me talking to the patient and three strangers. So it sort of brought together. I would never, or work very hard to never, be typing on a screen and talking to a patient at the same time.
Oh my
Maybe
goodness.
I'd make some notes, but
yeah.
To be looking at a screen and then glancing aside to a patient is They know your attention is focused elsewhere. So I would always try to give them my full focus. And this, let me tell you what the hardest part was, the absolute hardest part.
Please.
The absolute hardest part, after I do this little introduction stuff, I'd say, so how can I help you, or tell me why you're here? And then I would not talk for 2 minutes in a row, maybe even 2.5 minutes.
That was
I would
difficult.
just let the patient talk. Sure, because
Yeah.
in healthcare, normally we do this sort of rapid fire checkbox. Oh, you came in, David, with abdominal pain. When did it start? And does it, what makes it better? And did you have vomiting? Do you have diarrhea, allergies to food, other problems? And because I got to go down a checklist, check, 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 check. So we do this machine gun thing, and the person never actually gets to tell their story.